good planning. I'm a bit more of a free talker. So tonight we're going to talk about pelvic floor in general. So I'm going to brush over a lot of topics. There's a lot more we can go into. So if you, at any time you've got a question, you're just like, hey, put your hand up, or being pelvic floor health, if there's something you want to ask me or talk about in your own time, then you can contact me after tonight. No problems at all, because not everyone wants to talk about their pelvic health in public. So pelvic floor. So if we look at our pelvis, this is a female pelvis. At the bottom, we've just got muscle. So if you look at the bony structure here, the pelvic floor muscles make up the bottom of the pelvis, okay? There's no bony structure holding everything up. So our pelvic floor has three main functions. So firstly, it's to support our pelvic organs. So you've got your bladder sitting at the front here. Then you've got your uterus, if you have one, or if you're a bloke or if you've had a hysterectomy, you won't have that. And then bowel at the back, okay? So it's there for support. Secondly, it has a role in continence. So our pelvic floor contracts to keep us continent for both bladder and bowel. And then thirdly, it has a role in sexual function. All make sense? So here you can see the muscles in the pelvic floor wrapping around from the pubic bone around the back to the coccyx here, and then also along the sides. So that's the back, that's your coccyx there, pubic bone to the front. So I like to often show people this because it's a little bit easier in 2D form. So in terms of the bladder first, we manage incontinence and also urinary urgency. So you can have stress urinary incontinence, which is when you wee with cough, sneeze, exercise, laughing, which is pretty common, but it's not something that can, it's something that can be treated. And also, we also deal with urinary urgency. So that's when you're really busting and you can't hold on, you need to rush to go to the toilet. And you can't wait till you get there. You can have a mix of both. So you can have mixed incontinence. You can have urgency mixed with stress urinary incontinence. These are both things that we can help manage along the way. So some things that can affect your bladder's function is pregnancy, weight, childbirth. If you have vaginal delivery versus Caesar, more likely to have prolapse of the bladder. And then also other things related to urgency, in particular, are things that we take in. So bladder irritants, the main bladder irritants we talk about is caffeine, tea, yeah, I know, tea, soda, so anything carbonated, so soft drink and soda water, and then also alcohol. So other things also can irritate the bladder, like chili food. And it doesn't mean that these, when we say bladder irritants, they're potential bladder irritants, okay? So if someone comes and they say, oh, I've just got really bad urgency, I'm rushing to the toilet all the time, and we have a look at their bladder diary. So sometimes we get people to fill out a bladder, it's a bowel diary. Bladder diary looks like this. They fill out literally everything to actually measure what they're taking in, and also they measure what they're voiding, so what's going out. And we might look at that person's bladder diary and say, okay, you take in 8 cups of coffee a day, you don't drink alcohol, and you have soda water. So it's very personal for each individual, but we obviously screen everyone and try and get an individual picture so we can see what is and isn't affecting their bladder. Some people can have tea and they're completely fine. Other people have a warm drink and they know they're rushing off to the toilet, or some people use coffee for good bowel function, yeah? So other people have coffee completely fine. I'm sure you all know someone or yourselves where they have a coffee like, oh yeah, I'm just going to go to the toilet half an hour later. Yeah. So some people do use that to keep the bowels regular, but these are things that we can look at. So stress urinary incontinence, if we look at a side profile, this is a female, of the pelvic floor. So I like this image because you can see how closely the bladder here is sitting to the vaginal cavity, and then you've got uterus here and the bowel. So the bladder here, this little red bit underneath, that is your pelvic floor muscles around the urethra, so the sphincter there that closes and holds your holds everything in the bladder, and then also around the rectum. So same concept. So can't really isolate the front and the back, but they do all work together to keep us continent. So in someone who has stress urinary incontinence, it's because you're getting a big force of intra-abdominal pressure from above, so like coughing, sneezing, jumping, something like that, and your pelvic floor here is not strong enough to keep the force closure, so you get a little bit, could be a little bit of leaking, it could be full bladder loss, okay? And this can be various things like after gynecological surgery or vaginal delivery. There's some research to suggest that sometimes the urethra in a woman can actually be slightly widened, yeah, so obviously if you've got a nice narrow urethra, then you've only got to close it a tiny bit, yeah, but if you've had change in the tissue there and you've got a wide urethra, then it's taking longer, okay? Normally when we cough, sneeze, laugh, generally, in general, prior to having children, it's automated. Our pelvic floor should come on. Post, it's often something that we need to retrain and wake up again. Yeah, it's no longer automated. We think, oh, I used to cough, sneeze, and laugh, and nothing happened. And then after, or as we're going through menopause, it can affect that pelvic floor. With urgency has been found, depending, as long as you don't have, like, you're making sure you don't have an active UTI or infection or other reasons. We do look at what you're taking into the bladder, and then also sometimes bladder retraining can occur because you can untrain the bladder. So if for some reason, you might have had a catheter put in for surgery, or you may have had a baby, or you may have had a UTI, and if you've made prostate surgery for men, you may have had a urinary accident in public, and so therefore you're like, oh, that was embarrassing, I don't want that to happen again. It creates stress, so the brain, you become more in tune to the bladder, always listening to the bladder, and then often these people, they start to void more frequently. The just in case wears. So just going to void just in case before I go out. Just going to go to the toilet just in case before my Pilates class so that I don't go to the toilet. These are constant bladder emptiers. So because your brain is becoming so in tune to the bladder, you're making the bladder more sensitized, more hypersensitive. So if you haven't had a bladder issue, you just go about your day drinking. You might, be doing a talk to some people and think, oh, I feel my bladder filling. And you just push that aside and think, oh, hold on, I'll go later. If you've had an accident or you're incontinent and you don't feel confident to hold, then the stress and the hypersensitivity towards the bladder makes you want to void. Maybe you've only got 50 mil in the bladder. Okay, so it can become a negative cycle. Yeah, you become more in tuned into the bladder filling. You're getting more sensation at a smaller amount, and then you're voiding more frequently. Yep.
Do we accidentally do that to our kids? I honestly
just go to the toilet before we go out.
Yeah, go to the toilet before we got in the car.
Yeah.
Even if they're like, I don't need to, just try. Yeah.
It's not like obviously we would try and say to people, please don't don't go to the toilet just because, but there are times where everyone does that. Like, you're going to get in the car with your kids and drive for 5 hours, everyone is going to the toilet, or you've got a long movie coming up. Like, there's times, but if you're doing it all the time, every day, as part of your habit, before exercise, just because, I see people that go to the toilet before they go to the gym. They get to the gym, they go to the toilet, they work out, they go to the toilet. That is unnecessary, yeah? And that's just avoiding anything happening there, okay? So I'm going to explain to you, we like bladder retraining, but we do not do bladder retraining unless we've done a proper assessment, because, for example, recently had a lady come to me, said she had high urgency, but when we did a bladder diary, she was taking in 5 litres of fluid a day. So you can imagine if I taught her bladder retraining suppression techniques, I would it would not be good. Yeah. So it's not an appropriate case. So she's done the bladder diary, come away, and the biggest issue for her obviously is volume. Now I can't really retrain her pelvic floor, and I can't really teach her to suppress the urge until we get the volume down. So back on the topic of fluid intake is 1.5 to 2 litres a day of fluid, okay? Gym junk, with these ginormous water bottles and then the 5 coffees. Yeah, so just be mindful. If you're breastfeeding or you're super active, you can take in more, 2.5 litres. Some people would take up to 3 litres, but 5 litres is pretty excessive, and it's fluid intake. It does include tea, coffee, water. We want most of it to be water, because sometimes the bladder, like if you say to someone, oh, what do you take in? And you look at the bladder diary, it's just tea, coffee, soda water, like all bladder irritants. It's just, or they're not drinking enough. Sometimes the bladder's just acidic, or the bladder's just constantly only getting irritants put in it. It's not diluted, strong, potent urine. So yeah, it doesn't help. So that's why we try and go back and individually look at each person, so that then we can nut it out. And sometimes it's not one of those things where it's like, oh, you can't have coffee. But if we look at someone's caffeine intake and it's really high, and we can cut that back, and then they can see with that one change, it changes their symptoms, then obviously up to them about their level of worry about being incontinent or their love of caffeine. Yeah, but we try and do one factor at a time, because it can be very multifactorial. Okay, so if you get bladder urgency, do not try these techniques till you've been seen. But because it is a central nervous system driver, so come from the brain, we want to calm the nervous system. So my best example people can relate is, if you're like super nervous and you have an exam, or you're going to run a marathon, you're like, oh, you get there, I just really need to wee, put my pants before the race. Yeah, you're in sympathetic nervous system. You're like highly strung at that time. So you go to the toilet and you sit down, you're like, oh, I just did 50 mil. Like I thought I was busting. Or you may do a nervous poo. It's the same thing. Yeah. So your nervous system heavily interlinked with your bladder and bowel function. Yeah. So like if you feel urgency and then you're like, oh, I've got to rush off to the toilet, you are much more likely to leak during this period, because you're not focusing on anything, high stress, and you don't think about your pelvic floor, and then you rush off and you leak. The best thing for you to do is actually to stop, to sit down if you can, and then to wait for the sensation to pass. So to help the sensation to pass without panicking, we use different strategies. So pelvic floor muscle contraction, we use toe curling, brain distraction, so like thinking of female names starting with S. It's got to be hard. Can't be super easy, like counting ones, otherwise it won't work. And the other one is relaxed, like abdominal breathing. So calming the nervous system. You wait for that sensation to pass, and then you can stand and calmly walk off to void. Okay? Yep. Yep. Yeah, and that's what someone with a like a healthy bladder would do, because the brain distraction, because you're not, if you haven't had an episode, then you don't think about it. That bladder sensation that you carry does not come with stress. Yeah, does that make sense? So if you don't have an issue, you get a bladder sensation, you're like, yeah, I'll deal with that later. You go a lot about your life, you think, oh, it's starting to get pretty full now, I should probably go, but there's still no panic. If you have bladder sensation linked with incontinence, it's generally like, oh, I got to get to a toilet. So bang, you get the stress response, and then it just heightens the bladder sensation. Yeah. So it's a negative. Yeah.
Sorry, can I ask one sort of go along with that? It's something that
yeah.
Some people do. But like, you kind of go, oh yeah, I need to go to the toilet. It's like, so you get to go to the toilet, the more you're like, oh shit, I'm going to
Yeah.
Like it's when you nearly out of the toilet, all of a sudden it's like sudden urgency, and you're right there. Yeah. Absolutely.
Yeah.
It's like, how lucky are
So like I've had, you know, like for example, one of the probably most common ones, lady walking around the block, like, you know, every time she walks around the block, when she gets to the corner just before she can see her house, she's like, bang, bladder urgency. Yeah. She's untrained her bladder. Like she's trained her bladder, like key in the door. We all know key in the door, running water. Your kid's in the shower, you're like, get out, running water. Yeah. Like, yeah, all of that. So it's just that, like, yeah, negative bladder habits. Your brain's like, if you walked into a room with a toilet, like to not get a bladder sensation, unless you've probably just voided, would probably be unusual, yeah? Because our brain just goes, toilet, go to the toilet, yeah? Void. Yeah, exactly, yeah. So again, like if you find that it's, like, you know, you come home with the groceries and you're like, oh, I'm gonna wear my pants, I'm gonna get the door. Like try and like stop yourself, like walk away from the door, stand still or sit down on something, wait for the sensation to pass, get back up, put your key in the door, and you can calmly go to the toilet, okay? Yeah, I think like if you do have pelvic floor awareness, I think that like pelvic floor muscle contractions are my favorite because it means that you're kind of like, hey, can you actually wake up and do something so I can get to the toilet? But some people don't find in that time, in that panic easy. So obviously toe curling is like super easy, or they can, if they find they're really highly stressed about it, then the abdominal breathing, relaxed breathing can be really helpful. But we're waiting for that urge to pass and then off we go. Does that make sense? Okay, so something else that can really affect the bladder, which people don't think about, is actually your bowels. Yeah, so this is one of the number one things we screen for, especially post-gynecological surgery, prostate surgery, post having a baby. Do not get constipated, okay? So constipation is also one of the leading risk factors or contributing factors for women to have prolapse, because when you're on the toilet, you're straining, you can't be like, oh, I just like that force to go into my rectum. That intra-abdominal pressure that's pushing down, it's going to the bladder, it's going to the uterus, yeah? So prolapse is when you get descent of the pelvic organs into the vagina, yeah? So it's not like, it's not a super uncommon thing, yeah? Some women would have prolapse and be asymptomatic and wouldn't know. Other women may have large prolapse symptoms that do require surgery where the prolapse is external, and then other women are symptomatic, like I just sometimes have a prolapse symptom, okay? Now, if you're constipated, you're pushing down, then feeling weight within the pelvic area or within the vagina, just being constipated and pushing is definitely not helping your prolapse symptoms. So sometimes if someone presents with mild prolapse symptoms and there's, you know, grade stage 1, 2, and we think, okay, yeah, we can conservatively manage this, and they're constipated, the first thing we would do is manage their constipation, okay? We want, everyone gets to tell me what their poo looks like. So it's actually a really good chart to have. You should be. So what we're looking for is like a really nice, well-formed sausage stool, but it has, like, people will say, oh yeah, I have this, like type 3, 4. Yeah, pass this around, look at it later. 3, 4, but it needs to be like it must come with no straining. So if you're like, oh, my stools look like that, but really got to push it out, you're still like having factors of constipation there, yeah? We're having trouble with evacuation, okay? So we want this. Going to the toilet can be as common as 3 times a day or once in 3 days. It doesn't matter as long as it's this and you're not straining, okay? Because the strain down through the pelvis, not so much. I mean, for men, it's not great for hemorrhoids, yeah? They can get rectal prolapse, uncommon, but they can. But for women, especially long term, it's really important to manage for long-term health and also helping to prevent prolapse, and also for incontinence, because the pushing down puts pressure on the bladder, so it's just straining everything when it doesn't need to be strained, okay? So let's talk about pooing. So to go to the toilet, right, this diagram, so this muscle here Remember, this is your coccyx, this is your pubic bone. This muscle here called your puborectalis wraps from the pubic bone all the way around the back. So, all here, all the way around the back, like a sling, okay, like a U-shaped sling. Now, when you're standing and walking around, like me right now, my puborectalis is shortened, yeah, so it's contracted. Because if you imagine your rectum straight, yeah, it's contracted because it's a sling muscle, it does that so that nothing's coming out, yeah, it kinks the rectum. So it's on, so everything sits up here and nothing's coming out here, okay? So it's supposed to do that, which means that when you go to the toilet, you're actually supposed to relax your pelvic floor, yeah? So there shouldn't be that strain and it shouldn't be hard. So by relaxing the puborectalis muscle, rectum straight, freely come out, okay? Now, research has been found, so they've done research into the function of this muscle. So anatomically, pre-toilet, we would have pooed squatting, yeah? So squatting down. Then someone came along and invented a toilet, and now we try and poo like this. But it doesn't help us actually relax that muscle. So I'm sure some of you have seen toilet stools, poo stools. So big advocate for poo stools, especially like for men as well. It can be used, like we mainly talk about a poo stool for bowel function, so for ease of bowel evacuation. But stools can also be used for people who have like incomplete bladder emptying. So they'll go to the toilet and then they stand up and, oh, did everything come out? And that can be male or female, okay? So with a toilet stool, you want your knees above your hips, yeah, nice and relaxed upper body, and you want to let your belly hang out, yeah? So abdominal breathing, not bracing through your abdomen, yeah? Everything should be nice and relaxed, and you should get that feeling of relaxing through your bum, okay? So toilet stool, if it's too high, you can just, it doesn't have to be that. It depends how big your toilet is, yeah? But just, because people often say, oh yeah, I do this, like I put my legs up, but it's really hard to relax your pelvic floor if you're like doing that, because what you're trying to do is give yourself a toilet stool, but at the same time it's just easier just to use a toilet stool, okay? So this is for men and women. If someone has issues like with men post-prostate, they'll have like post-void like dribble where they don't quite get it out, or women who stand up and think, oh, I didn't quite get that out, or I leaked a little bit. Again, we would encourage men to sit to go to the toilet if they have trouble, or they have trouble getting everything out or starting, because it's easier to relax the pelvic floor, okay? And again, if you feel like you don't get everything out, people who rush, everyone rushing everywhere, weeing quickly, like, rushing off and then be like, oh, I've still got to go. Yeah. So just try and actually have a moment to yourself. You can use a stool. And if you feel like you don't get everything out, you can also try just leaning back, leaning forward. So just making sure the whole bladder is empty. Or some people, if they have trouble relaxing the pelvic floor, they may stand, like, do it, pretend I'm going to stand up, but I'm not, and then resit. Yeah. And just relax the pelvic floor. So if anyone has issues completely emptying.
Someone told me that, like when you think you've finished, just stop for a minute, wait another 20 seconds or whatever it might be, and then, I
mean, anyone with kids is like, I'm coming, just 1 second. Oh, my kid. Yeah. My son's just like, Mom, can you wipe my ass? And then I go in there, and then I'm like, Bud, you're going to school next year. You can wipe your own bum. He goes, yeah, I can, but not when you're around. But when you're around, I just call you and then you come and do it. I'm trained. Okay, so bowels. We haven't moved on from bowels, so I get sidetracked. So bowel health. So again, fluid intake, number one. Most people who are constipated don't drink enough fluid, okay? So number one. Number two, fibre intake. So if you're really constipated, first of all, I'll talk about this. We use Movicol a lot. There's some other options, but I bought Movicol. it is an osmotic laxative. So what it means is that it draws water in from the intestine, so your poo can't get hard. Yeah, it's like, it stays like a nice sausage and comes out, easier evacuation. This is for someone who's like, yeah, I do have type 1-2 stools. So we take Movicol to get on top of it, and then we try and change their diet and water intake to then counteract the Movicol. Some people live on Movicol. It's fine. It's better.
Yeah. I was sort of reading that that's actually not, I don't want to say the word addictive, but your bowel becomes lazy. So I've heard different things about that.
Yeah. We use it. I'm probably inclined to like use it acutely. So when someone presents with constipation, or for people who find, like a lot of people that they'll get on top of their bowels and they think, oh, when I'm at home and I'm eating well, you know, and I'm drinking, I'm pretty good. You know, I've got a regular bowel motion. Go to a wedding, eat crap food, have a lot of alcohol, and there's like getting backed up. So, you know, pack this in your toiletries bag. Just have some Movicol. Just home and they're not managed, so then it doesn't allow. So if you get in,
I noticed it.
oh my god, I broke it.
It was flashing. It was flashing. It was flashing.
I told you I'd hit it. Like this one too. Okay, so what was I saying? So kids, so they go into hospital, they get disimpacted. But if they're chronically constipated, you can actually stretch the rectum. So the rectal tissue is they are not actually aware of when they need to go. So you actually must avoid them being constipated. So the tissue can slowly but surely, for like up to 12 months, ideally shrink a little bit back to its normal size. Whereas what happens if they get impacted and they go home, they get constipated again, the tissue is so stretched, they don't know when they need to go or not go. They're actually not getting the right sensation in the rectum. Yeah. For kids, like good bowel habits, so trying to get them to pass using a stool that's like for a kid, and then good bowel habits, so trying to go after like 20 to 30 minutes after a meal, like belly breathing on the toilet, making a good experience, like all those things. But if I understand like medical, but it's something that you could also speak to a dietitian about. It can be hard, like, you know, if you have some people say, oh, I've got a kid, you know, autism, that kid ain't going to eat whatever you give it. Like, if you can get Movicol into them, you know, and this is how you manage them, taking Movicol is better than having an impacted over and over and over impacted bowel, because he's going to, like, that kid will end up with way more health issues and concerns down the track. I understand Movicol is not ideal, but especially if you're dealing with kids that are like have trouble with texture, have trouble with fruit, you know, they eat pasta and cheese only. Like, it depends on the kid, like what you're dealing with, you know, what they're happy to change. Sometimes it becomes a bit easier as they get a little bit older and you can actually have the conversation with them. Yeah.
We've been doing the Movicol for 6 months, but then we're having a different problem. So I'm like agreeing with everything you're saying. It's like, yeah, we do the watered down juice, we try and do lots of fruit, but it's, I don't know. And then like time helps, but it's like, we all have to have a conversation and argue with us, but I can freaking eat. And then she also can't do it.
The water for me is a struggle to get it.
Yeah.
We have so many straws.
Yes.
Yeah. So with kids, just quickly, like, if they have a painful episode going to the toilet, then they're likely to withhold, which then means that the poo gets even drier, which gets even painful. It's a negative cycle. So we've got to make it soft and happy and easy to pass, and oh, look, it's good and it's a joyful experience, and do you want a sticker, and here you can, you know, like stick stuff up in the toilet and like sing some songs and whatever you want in the toilet, because it's the negative. They're just like, that was painful, I'm not doing that again, just like an adult would, but we just mind over matter is a little bit easier for us, so they just go, I'm not doing it. So they hold all day at school, they hold all day, and you're like, what's wrong, we're so irritable, they do a big poo, and then finally they feel better. But you really have to try and avoid any painful poo. Yeah, because otherwise you'll get this many steps forward and then you just end up coming back. Yeah, no, like, yeah, it's a whole other like topic. But yeah, a good pediatric dietitian, but again, just someone who's happy to work in with your kid, because they're not, you know what they're like, you know, eat your food. No, I don't want that. All right, so got off topic. Good. So let's talk now about lube. So, yeah, lube. Okay, does anyone know the hormone that you are lacking when you're pregnant, breastfeeding, or menopausal? Correct. Tick, 5 stars. So during that time, so we need estrogen Women need estrogen for many things, but also it affects our vaginal tissue health. So for some women, they find, like when they're pregnant, breastfeeding, or menopausal, that they get like dry vagina. They see vaginal tissue change. So they like vaginal tissue thinning. They may experience discomfort with intercourse that they have not experienced before. Irritable skin in their undies, things like that. We always recommend the use of lubricant during those times in your life. Water-based lube needs to be used with condoms, but it doesn't last as long. So this is like, feels good at the start, but you may find that halfway through it's not lubricated enough anymore. So it's good, but water-based lubricant is, it can be a little short-lived. Silicone-based lubricant. Silicone-based lubricant lasts way longer. This one, Uberlube, comes in this really cool little like fun size, like travel. You can just like pack that in, travel pack in your toiletries bag. Look at that, it's so cool. It's like a lipstick. But it lasts like way longer. You just keep rubbing and rubbing and rubbing and rubbing and rubbing. The silicone's not going anywhere, yeah? But you just got to make sure you don't have like allergies to it or anything like that. If you're someone who has super sensitive skin, it's always worth speaking to. Yeah. And actually, I know it sounds silly, but if you are someone with like super sensitive skin, it's actually not. You can go to a sex store and they should actually be like, hey, I've got super sensitive skin, I get dermatitis or eczema or whatever you're getting, and they should actually be able to direct you in the right place. The other one, this is a natural product. I sell this. It's called Olive and Bee. It's an Australian product. It's olive oil and beeswax. Can't be allergic to bees and use this. But otherwise, it's pretty good. And also you can use this just as like a personal moisturizer. So for some women, going through that time in their life, they just feel like their tissue is a little bit dry, irritable, like around the vulval area. So in their pants, they may feel irritated. You can just use this like moisturizer. Does that make sense? Anyone else want to ask anything about that? No. So with the other thing about vaginal tissue, which I want to talk to you about, is lack of estrogen. So more and more now, like postpartum, any birthing trauma, gynecological surgery, hysterectomy, bowel cancer, radiation to the pelvic area. More and more now, the research is pointing towards topical estrogen cream to be used for vaginal health. Yeah. So if you know someone who's like having any kind of radiation to their pelvic, like including like bowel, that if they're not managing their vaginal tissue health, you can end up getting like adhesion, like your vaginal walls can adhere together. Yeah. So if you know anyone going through these things in their life, do encourage them to speak to their GPs about the option of estrogen, topical estrogen cream. It is found to be safe to use even if you have history or have had breast cancer, because it's topical. It's just going to the localized area. It's not. And you can it comes in either a cream or a little pezzery. You just pop up in and then releases the estrogen. But really important long term for vaginal health, especially if you don't have any issues postpartum. Great, you don't have birthing trauma, anything like that. But as you hit menopause, if you feel like you're getting like thinning of the vaginal tissue, just like the rest of our skin as we age, then it can definitely be used, especially if you're experiencing discomfort with intercourse. I will briefly talk about vaginismus, vaginismus is the involuntary pelvic floor muscle contraction or spasm with any form of vaginal penetration. So some of these women will report inability to use tampon even from a young age. They may not have ever achieved penetrative sex, and they often, if it has not been addressed, have had painful sex for their whole lives. This can be long term or it can be acute episode. This can also be obviously this is a term used to diagnose someone in particular, but also it does coincide also with someone who has high tone pelvic floor. So you can have incontinence and you can have a really high tone pelvic floor. So really, really tight pelvic floor, because what happens is all day your pelvic floor is on and it's just on. And these are often people who are like highly strung. Yeah. Like super stressed. Yeah, and they're just, in the fitness and Pilates junkies, gym junkies, athletes. Stress urinary incontinence is found to not be uncommon in female athletes because their pelvic floor is on all the time, and then they just do the extra 100 burpees and their pelvic floor is like, it's on all the time and doesn't have the give anymore. It can't hold anymore, and so it lets go. Okay, so you can have a high tone, too strong almost pelvic floor, because the important thing is that your pelvic floor can be in a state of relaxation, but it comes on functionally when we want it to work. So we want it to have this mobility. If you assess someone with a high tone pelvic floor, they're like, yep, I can feel you're on. Yeah, can you let go? No, can't feel the let go. Like there's just no let go. It's up here. Yeah. So their ability to actually relax. So then it crosses over into being like, actually, I need a strain to go to the toilet because they can't relax. Yeah. 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 Right. Well, high tone pelvic floor. This is also relevant. Like again, like we don't talk about it enough, but like gynecological surgery, postpartum, like returning to sexual intercourse, like it's super important. We want this to be a good experience. We want women to use lube so that they're avoiding the pain, because to have pain-free sex, you need to be able to relax your pelvic floor. So literally your pelvic floor, it's like, I imagine it's like, getting an injection in your arm. Before the injection, say you're already like pulling away, like just relax your arm. It is relaxed. What do you mean? It's completely relaxed. Like involuntarily, you're already pulling yourself away. If you've postnatally or for whatever reason experienced pain with intercourse, then already you're thinking, before it even happens, you're probably like, might happen tonight, my partner or someone, and you're thinking, already your brain's anticipating the pain. Yeah. So remember that pain our brain can produce pain from actual tissue damage or the perception or anticipation of pain. So if you've had painful intercourse and then you're like, yep, it's happening, you're just going to be like, you're thinking already this is going to be painful. So your pelvic floor goes, no. Yep. But in your subconscious, by having a really tight pelvic floor, it doesn't help because it actually makes it more painful. Yeah. So these women need pelvic floor down training. They need to learn to relax their pelvic floor, let go, be okay. We do use a sport this in. It's a silicone vaginal dilator. It's like super flexy and bendy. For some women that want to work in this space on their own, because it's very complicated, space in terms of feeling comfortable, and also, how supportive is your partner? Do you have a partner? Do you not have a partner? All of those things, that whatever goals you want to achieve. We use vaginal dilators for people who want to work on this in their own time, or just feel like they can't achieve relaxation in the moment, so they can go away and work on it and be like, actually, come in different sizes. So then you can, if in your own headspace you've been like, I've been able to achieve pain-free vaginal penetration with my vaginal dilator in my own space and I'm feeling confident about it, then that person can introduce and get their partner involved, and it can be a process, especially if some women, they've never not had pain-free sex. They don't even know what it feels like. They've never had a tampon. They can't get a tampon in. Yeah. So that's the extreme version. For some people, it's postpartum, we're just avoiding the painful experience, or making sure that if it is like that, we get on top of it straight away, so that then we can help manage it and guide, so that someone doesn't just say to you, yeah, just keep doing it, it'll be fine, because it doesn't work like that. Yeah, you can easily create that negative cycle of, that was painful, the anticipation of pain, pelvic floor says no, it was painful, yeah, just again it can become worse, and it's very intimate part of everyone's lives, so it's important to talk about. Any questions? No? Yeah, I've got some sheets here on the estrogen cream. shit on vaginismus. You can have a look, pelvic floor questionnaire, which is what I use to screen. Well, I just get people to answer this before I see them. So it just gives me a rough idea what's walking in the door, and then where I can go further down the track. Also, we also talk about things like I love to see women while they're pregnant, because it means we can talk about things like perineal massage before they have babies. Clinically, research has proven that it can help reduce tearing during pregnancy. Talk about warm compress during second stage of labour can also help reduce risk of tearing. Perineal massage, managing that process, making sure we're desensitising the area. You know, a lot of women don't want to look at it, they don't want to touch it, or they've had gynecological surgery, just like, oh, avoid it, it'll get better. Doesn't work like that. Yeah, just going through the process together to make sure everyone's comfortable and everyone's fine, everyone's continent, you know, managing the bowels, all of that together. Can also help women, educating women about birthing positions, your birthing risks, and things like mastitis care, and yeah, and getting back to exercise and getting back to Pilates. You know, at home where I work in my clinic on the property, often I have women come back in and they want to get back to MS class, but they're just not quite confident. They may have had a little bit of incontinence, or they may have a bit of prolapse, so they're just not really sure. And so in that space, I can work with that person. You know, do they want a home program? Do they want to come in? I've got a reformer at home. You know, often what we do is we work towards being able to do a session together here in our individual space and be like, yeah, tick, high five, you're ready to go back to Emma. Because sometimes if that doesn't happen, that person never returns to Emma, and everything's, what happened to that person? Yeah, and they just never come back because they haven't had the guidance and they're not sure. Yeah, returning to running, returning whatever your goals are. You know, for some people it's just to. Yeah. Yeah, that's pretty deep. Yeah. More like, you know, it could be yeah, like not having to rush to go to the toilet, or not having to wear liners. Yeah, not having to wear liners, and you don't have to have kids to have these issues. Yeah, I see young kids as well. Yeah, with incontinence in their teens. Often because of constipation, or like chronic UTI, something sparked it.
What about kids in their late teens that are still wetting the bed? Do you know much about that?
Yeah, have they had their how much urine are they producing overnight? They probably should go and get urine done. Yeah.
We'll have a chat to you afterwards.
Yeah, it can. It's definitely like, yeah, in teen, it's not uncommon. Obviously, sometimes kids do wet the bed, but we do try and manage like fluid intake at the end of the day. Like, are they getting home being like, oh, I haven't drunk anything, 2 liters, and then at night their bladder's full, or are they getting nocturnal polyuria? Don't quote me on that, pretty sure that's what it's called. Polyuria, where it's actually overproduction of urine at night. So they're getting daytime volume of urine production overnight. Yeah. Have you used bedwetting?
It's not for me, it's a girlfriend's child.
Do you know? So
I think she has
so the bedwetting devices are like really good. Like you've got to go hard. And if you don't have a kid that wakes up, you need to be like in there waking them, you know, so that they learn to wake up. But if they've never been like properly checked, it's just worth like seeing how much they're actually voiding, because overnight our kidneys are supposed to, there's a hormone, can't remember what it's called, but it slows the production of urine overnight. So you've got night prone production, that's why you're supposed to go through the night, and then you've got daytime. And if you're producing daytime, there's actually medication for that. Yeah. So I'd be surprised if they hadn't gone down that alley.
I reckon they've done just about everything, but like she's at the stage now where she's, you know, got a boyfriend and she's still wearing a nappy at night.
Yeah.
It's just terrible.
Yeah, and no incontinence during the day.
That's what I'm thinking. That's what we've said.
Yeah, and like no incontinence during the day. Nothing.
I don't think so. No. So it's just sort of
It's just like, it's one of those things where just and like, even like for someone, you know, that I see, I always say to people, like, just get in contact with me, like, especially like, you know, postnatally, like if you feel like you need help breastfeeding, you need a lactation consultant, you don't know where to go, like just I'm happy to help you find that person.
And I'll vouch for Jen. My daughter's 24 and started seeing Jen. Before she was seeing Jen, she was seeing chiro, myo, and physio every second week. She's been seeing Jen.
Nice. I'm a normal physio too, but I just not advertising it. Yeah.
Normal physios.
Yeah. So, yeah, as in like, you know, normal physio stuff, but
I was going to
yeah.
real
Yeah, I don't really, you know, this is my thing now.
She's a specialist. That's special.
Yeah.
My normal physio is vaginal.
Yeah. Mainly the people I see now because of where I live, and I see a lot of horse riders that you know, we do like return to riding rehab a bit, but that's just because of where I live. Yeah, and I have a riding background, so it's easier for those. What do you mean I can't ride my horse? Type of people. Yeah, I'm only 2 weeks post-op. Just get back on. It'll be fun. Yeah. Yeah. Yeah, and it is super important. But it's a really important space, and just checking that like people are getting help, because you know sometimes we wonder why maybe our friends become a little bit introverted, or they're not coping postpartum, or you know they seem abnormally stressed, or they don't want to go out, or you know there could be underlying issues there that you know may end up resulting in a big. I would love someone to do a research paper on postnatal depression and seeing whether it ties in with pelvic floor, because it's not like you don't go to your friends and say, oh, you know, you're like, oh, my shoulder, it's just killing me today. Everyone comes over and says, oh, how's the baby, or you know, how are you doing? And that woman's probably like, yeah, I'm like wetting myself every day, but it's not something that they, you know, most commonly bring up with their friends. So it's very, very like it's very heavy. It's very personal issue, and pelvic floor pain, which is a whole other topic, is heavily interlinked. So people who suffer from things like vaginismus or bladder pain syndrome. Some men get like pain with erection or ejaculation, or endometriosis pain is heavily linked with mental health. So there's a big umbrella there. The more research they do into those areas, because your mental state, you know, directly the vagal nerve coming into the pelvic floor, responsible for your sympathetic and parasympathetic state. It just correlates in with the pelvis, because with something like endometriosis, is a really great book going on endometriosis. The more like they used to operation after operation after operation after operation, but these women can represent with pain, their pelvic pain, and they scan, they're like, there's no endometriosis. What's going on here? Yeah. So it's not to say that endometriosis doesn't cause some women a whole lot of grief. Yeah. But for some people, there's another underlying cause or contributing factor into the whole picture where these women are getting surgical intervention, but actually they've got a history of past trauma and no one's dealt with that. So they go and get their endo surgery. It doesn't resolve their pain, or they represent with their pain and they look at them and they're like, oh, there's no endo, because you can have endometriosis, signs of endometriosis for some people, and they scan them for something else and they're like, yeah, you realize you got endometriosis? No symptoms. Yeah. Someone else, no endometriosis, or representing post endometriosis with pain. So obviously, again, individualized, but we must not push aside the mental link. And again, for men suffering any pelvic pain disorders or erectile dysfunction, again, your CNS, brain driver, heavily contributing factor. Again, seeing, overactive bladder pain syndrome, pain to the bladder, goes back to the, mental and physical connection. Yeah. Does that make sense? There are some great books. Anyone going through prostate surgery, men that don't want to actually come in and talk to anyone, this is a good book. After prostate surgery, you're all statistically, it's pretty rare to not have any form of urinary incontinence, because it's male anatomy. I held the female on the whole time. You can see the prostate literally wraps around the urethra, yeah? So when they remove it, especially if it's been enlarged, it's almost like providing forced closure. They take it away. And it's just like, yeah, it's just like, oh, because an enlarged prostate can affect how the pelvic floor muscles work. And sometimes it actually is masking incontinence. And they take an enlarged prostate away. Your pelvic floor is like, hang on a minute. This is like a void, yeah? And so the forced closure of urethra is not there. But it can be treated if men, you know, like are confident to come in. No. It does, like some just like from, well, obviously it depends on their prostate health, but any man who's having urinary issues should always just go and get their prostate cleared. Like I would not be treating anyone who has, yeah, any in that area, especially. Are you saying prostate cancer but not removed? Or you still had like radiation to the area? Yeah. Yeah. So radiation, chemo, all those great things. And then these are just other books on pain. Yeah.
Selection as well.
Yeah.
Father-in-law probably do with that. He's just had his
Yeah. It's just like, obviously men, they don't want to talk about it like often if they're super blokey, but it is like for men we can do pad weight diaries. So post prostate surgery they may be wearing a pad. We actually get them to weigh the diary, so then they can, when they're going through and doing their pelvic floor, they can actually see, because it's hard. It's like, are you leaking? I'm still leaking. Yeah. But if you're actually weighing the pad, then the bloke, it's half, you know, they can see the progress and it helps motivate them to go on. Not all of them want to do pad weight diaries, but it can be helpful for them to see that what they're doing is being effective, and again to get the confidence. No different to a female wearing a pad, yeah, a male wearing a pad, yeah. To get the confidence to not need it, or and to get their lives back. These men will like withdraw from golf and social activities, and they often sometimes go into a shell. Women sometimes are a little bit better at dealing with all those personal things, chatting about those things. And
well, it's just like how you said just as well, like, you know, people are happily to come up, the people tell me all the time, like I could be out doing something, I've got this sore shoulder, I've got this thing, but no one's talking to me about their vagina. Well, they might. Sometimes I get like sort of curveball kind of questions, but it's something that really needs to be normalised. I just feel like it's just a part of our body.
Even and sometimes like coccyx pain, for any therapist in the room, like chronic coccyx pain, it can, like, you know, you're just treating it, you're like treating lower back pain, coccyx pain, think, why is this person getting better? It can be the pelvic floor, so it can be hot, like so tight, so on, it's pulling on the coccyx, and it's got nothing to do with the coccyx. It's actually the pelvic floor. So anyone who chronically suffering those issues, we always like refer them to a pelvic floor physio to get them checked. You can still treat their back, but like you're just making sure that there's not a missed component, especially if they're not resolving, you know. So I work out of my property. So I had a clinic in Vermont. I was there for about 10 years, and just COVID, and then got through COVID. No, sold up and moved to closer to home. I got 2 kids, so 6.5-year-old girl and 4.5-year-old boy, and I just didn't need to be commuting and getting home at 10 o'clock at night. Then transitioned more into pelvic floor health. I've done a postgrad degree at Melbourne Uni in pelvic floor space, and then now it's just me. But I can see EPC, I can take Medicare, Medicare occasionally. I mean, work cover's pretty rare for pelvic floor, but I can definitely take a EPC. And if they're really strapped for cash and it's a problem, then we try and it's just me, it's a worry, so I can try and spread their appointments out to make it last, so they don't feel like they use up all their 5 appointments and they can't afford to come back. So just like I can work in with the person. Some people like they want to get on top of it. So we try and do it intensive. Other people, they've got things in their life happening. So we just work around what they need.
So, thank you very much for coming tonight.
Sorry for breaking it.
Does anyone... No, you didn't break it.
It was on the ground.
It was a fuzzy thing. Back up on you because you've got little questions.
Oh, okay.
So, does anyone else have anything that they'd like to ask Jen? Like, we're a very safe space, girls and boys. If anyone would like to ask anyone anything.
Is it normal pre-period and after period to be constipated and diarrhea?
Yeah, so bowel change super common. Yeah, within period. So maybe that's a time when you just aware that you need to be more on top of management. Also not uncommon for women to experience to feel like they get their prolapse symptoms during their period.
Because of the weight of it. Like
It's not uncommon. Yeah, so if they've had prolapse symptoms, to feel, because just the weight of the uterus, the weight, down. Yeah, and some everyone's variable at the weight of the uterus. So some women who have had prolapse symptoms for a long time, sometimes when they get a hysterectomy, they're like, oh, actually my bladder prolapse because no weight, the actual and again the anatomy there, the weight isn't there on the bladder. So sometimes that can help. Sometimes it doesn't.
It's all they get a hysterectomy.
Let's not.